Hello and welcome to the Surgical Spirit podcast. I'm your host, Dr. Haidar Al-hakim, the Third Eye Doctor. Pull up a chair and get ready for some candid and uncompromising discussion with experts, innovators, agitators, and influential people from every corner of health and well-being. From inside the hospital to at home in the kitchen, we're leaving no stone unturned in our quest to uncover the secrets of healthier, happier, more successful, and less stressful lives. Thank you so much for joining us, and without further ado, let's meet this episode's guest. Hi Rachna, thank you so much for coming on the podcast today.
Hello, thank you for having me on.
Great. You know, this is the current reality of life where we're at the behest of internet connections and sort of the virtual infrastructure, unfortunately.
No, that's fine. If there's a long delay, then it's my cogs working rather than the internet. But yeah, hope it will hang out.
Yeah. So, you're interested in surgery, which is really cool, because, okay, I'm being a bit old fashioned here. Back when I started medicine, there weren't many ophthalmologist female surgeons. What was your experience of that?
Oh God. Well, I think when I first started out, and that was a long time ago, I'm sure actually it was probably before you, although it's very, very charming of you to say that you started much earlier than me. No, I mean, I went into medical school in 1989 and I did an intercalated BSc and qualified in 1996. And at that time, there were still more males than females in medical school. I went to medical school in Imperial College, and it was very, very sort of male dominated actually, and very few of us females and males wanted to go into surgery, but the vast majority wanted to go into surgery. I was born into a medical family, so I was very, very sort of conditioned to be either completely pro-medicine or completely against medicine. And from my personal sort of experience, my father was a plastic surgeon and my mother was an anaesthetist, and they both came to the UK and had to really didn't see career progression, unfortunately, because of various reasons, even though my father was a gold medalist in India. And my mother was pretty good, pretty hot herself as well. But she was told in her medical school, the same one as my father, a very well-known one in India called CMC Vellore, that she should become an anaesthetist so that she could support my father, the surgeon. I mean, she may well have been a surgeon. Who knows in those days whether there was more difficulty for females to become surgeons. But anyway, she was told to become an anaesthetist to support my father. And they worked in a mission hospital together in India, and then came over to the UK when I was 4 and my younger brother was 2. And I grew up in a medical family, and I grew up seeing a surgeon and an anaesthetist work very hard in the UK. And my father worked with burns plastics in the plastic surgery department at that time that was in Billericay in Essex, and then later on moved to Chelmsford. Well, very well known burns unit, because that's where Macindoe and a lot of the well-known surgical teachers who developed the techniques for plastic surgery started. And so I would hear about all of my father's work, and some of the sufferers from the Falklands War who are pretty well known, and we won't mention any names, but there was a lot of excellent work being done, and I I really became interested in that aspect of it. I also, have this keen interest in the aesthetic side of things, and I enjoyed art and painting and drawing, and these were all the things that I liked to do when I was growing up, and the sciences as well. So I was in two minds as to where I would go, but of course, coming from an Asian background, there's always this immense push, more to my brother really than to me, that we should be looking at a profession, and a profession being something like medicine or law or engineering, or all those sort of nothing to do with painting and drawing and art. But I knew that that's where my passions lie, but I also really enjoyed sciences as well. My brother actually was going to do medicine as well, having grown up in the same family, but he hated blood, and he now is, he ended up doing a pre-med degree in the US, so he left the UK for other reasons. Again, I think he sort of got to a point where he was a little bit disillusioned as well, and he went to Harvard, and he's now a very well-known person in mergers and acquisitions in the US. So, clearly medicine wasn't what he was meant to do, and but medicine, I think, was what I was meant to do.
I mean, was that more of a duty, because you mentioned push there? Or was it just sort of a natural transition from, for you as a young lady?
Yeah, I think for him it was more of a duty.
Yeah.
Or he felt that he had to do that and end up doing that. For me, it was a natural transition. I was also the eldest, and so I suppose there was a little bit of responsibility there to do something that was reasonably professional, but also it's a caring profession. Medicine is a caring profession, and one thing that I do well, I feel, is care. And so whether that's caring for siblings or caring for friends, or now caring for the older generations and patients, that caring had to come into it, and being able to do a job or a career that gave my father quite immense satisfaction, and my mother immense satisfaction in terms of looking after patients, however hard they worked and however tired they were when they got home. I knew that they got a great deal of satisfaction from their work, and then that's something that sort of drove me as well. And it was just natural selection. I was going to end up in medicine regardless, and I was going to end up being a surgeon because of the artistry, I think. But the ophthalmic side of it, that was an interesting decision, because in medical school at the time when I was there was a stint where you have, which you probably had as well, and where you go through your training attachments for the specialties. And so dermatology and ophthalmology was always sort of grouped together, and it was called Derma Holiday. So Derma Holiday being this time where most people didn't really turn up to the clinical attachments, and it was a holiday time. But I, having seen my parents work very hard and in their careers, I didn't really want to be up all night in whatever I ended up doing, and actually. Derma ophthalmology holiday, as it was called in Imperial, was something that I was actually thinking about as a career. So it was either going to be dermatology or ophthalmology, and I actually decided to be a doctor when I was about 8. I was going to be a pediatrician at that time because I enjoyed looking after children or being with children, and I realized that actually that was the wrong thing when I got into medical school, because you were then looking after the parents rather than the children. And so I then
what happened when you were 8? What exactly happened?
Well, I played with Meccano more than I played with dolls, but I had a younger brother, and I enjoyed looking after him. And I think that it's just default, maybe as a female, that you want to look after children, and so pediatrician was what I thought I was going to end up doing.
I mean, there wasn't a child that you kind of, something happened, or a particular story that happened at the age of 8 that was really significant.
I think 8 is about the time when people were asking me, and it's interesting actually, because I have an 8-year-old and a 10-year-old, and now is the time when we're sort of having those discussions again about what they might want to end up doing. And it's suddenly transitioned from being an astronaut and the youngest was wanting to be a doctor because he's seen 2 parents as doctors again, but actually he's changing his mind now, and he's looking more at his uncle who's in the States and heading off in that direction. But yeah, I think it is around the time when children sort of start to get asked the questions and start having to think about those questions. So that was when I was asked. That's when I sort of decided that it's going to be medicine, and I just stayed on that track. But so ophthalmology, dermatology were the 2 specialties that were grouped together in as an attachment, and they were, funnily enough, the 2 specialties that I'd been thinking about, because they both offered an opportunity to be on call and be able to sleep. And I thought that was quite an important thing. With dermatology, I expected that there would be more emergencies at nighttime when you might have to get up, and with ophthalmology, of course, very few people lose their sight when they're sleeping. So it's got to be a traumatic event or something else. And so that's why I started thinking in those terms. It's an interesting way of deciding the career specialty. But I also had this fascination with eyes, and for my final year as a school student, I was the artist for the school magazine cover, and I decided to draw an eye. My own eye, but it's something that I'd sort of studied in terms of the artistry rather than the science. And I think it was just at that time that I had this epiphany that actually, I went to all of the surgical attachments, and I assisted and got as involved as I could at the Western Eye Hospital, and really, really loved my attachment and time there. And that's when I decided that this is it. I want to do surgery. I love medicine. I love art. I have this interest with eyes, and this is what I'm going to end up doing. So yeah, that's why I specialized in ophthalmology. And then later, after completing my ophthalmology training and going through oculoplastics, I realized actually, I love the plastic surgery side of it.
Yeah.
And that's
going back round sort of to the same origin. Full circle. Yeah.
And at least being able to use some of my other passions in my work as well. So
it's interesting.
Yeah, and that's where I ended up
what difficulties did your father go through back then, and what really struck you as a young woman?
So I think for him, there's always racism. We have to bring up the R word, and it's sad that we still have to bring up the R word, but there is always racism. The vast majority of the medical junior staff at that time were Asians from the Asian subcontinent, or from countries where Asians were, and they are still the vast majority, I think, of the backbone of the NHS, and supports the NHS at the moment. But there was a glass ceiling for them, and I think there is still a glass ceiling now, although it may be for different reasons. And so for him, even though he had the immense skills and he was teaching others of his sort of junior doctor colleagues who were born and bred in this country, they were going to get the promotions. But I think it's also a little bit to do with culture and fitting in and who you know. And I don't think I can entirely sort of blame racism on his lack of career progression. but I think that had something to do with it. And in terms of the sort of the male-female aspect of it, so although I didn't have any issues that I was aware of in terms of racism during my training, my issues came in with the gender, I think. So you're right. I mean, we started this conversation at the beginning talking about how it has been as a female in surgery, and that's where the numbers started to dwindle. So once you get to ophthalmology, you still see a lot of females in ophthalmology, even though the ratio is still greater, male-female ratio is still greater. There are still a lot of females in ophthalmology. But when you get to the plastic surgery aspect of ophthalmology, the numbers shot right the way down. And in fact, I was probably one of the a handful of female consultants, in fact, possibly one of the first brown female consultants in oculoplastics in the country. There are significant hoops to be jumped through, and there's a big bottleneck, but I made it. And I made it through sheer hard work and determination. And also, there's something, I mean, a lot of your listeners will be probably medical, but if not, then in terms of training, after you've finished your medical training, you do your specialist training in terms of whatever you want to do. So ophthalmology was then 6 years at least, if not longer. And so I got my consultant job in 2009, but that was after 3 years of doing something called a fellowship. So a fellowship is super specialized training after you've qualified from ophthalmology and you've made a decision to subspecialize into a different part of the eye. So we're no longer general ophthalmologists like they were in those days. And oculoplastic surgery was an entity in 2006 when I started my fellowship training after I finished my ophthalmology training. So I went to Australia for a year and I did a very well-known fellowship in Melbourne and worked with an excellent oculoplastic surgeon called Alan McNabb. Learned all about skin cancer work because there's a lot of sun exposure and sun damaged skin in Australia. A lot of the functional skin cancer surgery hands-on training I got from there, I brought back to the UK and was able to use it in my Suffolk population, which is also a retiring population with lots of skin cancers. And it's a very specialized area to deal with. It's not the same as doing plastic surgery on the cheek or on the forehead, where you don't have to worry about an underlying structure which can be damaged and which serves this important role of vision, which is probably one of the most important senses. So that was my first fellowship for a year, and that was a great year to be out in Australia and sort of get some experience, but also enjoy some sunshine and get more towards an end goal of becoming a consultant in oculoplastics. I then, following that, got a fellowship in Moorfields Eye Hospital, which is the most well-known hospital in the UK for, or it was at the time in the UK for ophthalmology, and it's there that I got more experience in sort of orbital surgery, lacrimal surgery, so watery eyes, and also much more hands-on training. And one of the things we sort of briefly chatted about before the podcast started is that, at that time you were just thrown in at the deep end. You just got on with things. And so I was the senior fellow because I'd done a year of oculoplastic training elsewhere. And so I was then training all the junior fellows who had not had that 1 year of training. And I was also not supervised by consultants, and I was looking after patients with quite significant disease in an operating list that I was running by myself, which is at that time, it's a consultant level list. So you were left to get on with things. And that's where we learned, and that's where we picked up our skills. That's where I picked up my skills in terms of efficiency and honing my surgical skills. But I also knew I wanted to do aesthetics as well. You know, the aesthetic aspect of surgery. And so I then went on to work with another really brilliant, well-known surgeon called Naresh Joshi, who is well known for blepharoplasty surgery and cosmetic eyelid surgery in this country, and worked with him to just assist in the private sector and learn about cosmetic eyelid surgery. Not that I would necessarily be applying that until much later on, it turns out, but it took me 3 fellowships to get a consultant job, and that consultant job, I had to wait for someone to retire. So in ophthalmology and in most consultant posts, we have to wait for somebody to retire or die before we can get the job. And so I was probably going to end up in London, but I didn't, because there were no jobs available at the time. And I was not going to wait another, I'd already waited 3 years doing fellowships, but you know, I was relatively old in inverted commas when I got my consultant job. So normally
very experienced.
Experience, yes, very experienced. So I got there 3 years after most people, and I got a job in Suffolk, in Ipswich, and that was combined with Cambridge University Hospital in Addenbrooke's. And so yeah, I thought that's great. You know, I've got there. This is amazing. I've managed to jump over all the hurdles and deal with all the struggles that my parents had to deal with, and I've got there. And it's, you know, it's amazing. But and there is a but. We're not really sort of as medical students. We're always just geared up to that end point. That end point being getting the consultant job. Then what happens after that? It's not something that that we are sort of that we discuss or we're asked to think about, and you know, then you're then left to just get on with it, and you then have to think about, well, you know, this is it. It's taken me 10 years to get here or more. What am I going to do now? How am I going to? What's my next goal? And I'm very goal driven in that way. In that, you know, I need to have some form of stimulation and something to do to improve on what I do. And so you know, I developed the services, and in Cambridge I set up now an internationally recognized thyroid eye disease service. And so thyroid eye disease is a very sort of subspecialty part of oculoplastics, and it's not an uncommon disease, but so we see this endocrine problem called Graves' disease, where there's an overactive thyroid, which is not uncommon, and about 5% of people with Graves' disease develop thyroid eye disease, where people can develop large, sort of massive, bulgy eyes, and that can result in loss of vision, and it's still a blinding condition. So you'd think that, you know, in ophthalmology we are able to cure most things, maybe not macular degeneration completely yet, but most things we're able to cure. But thyroid eye disease is a blinding condition that we still do not have a cure for, and it was something that I decided, actually, you know, there is an unmet need here. There is an unmet need here because we don't have a cure. And we also have a group of people, the vast majority of patients who have the thyroid eye disease are females. It's an autoimmune condition. And it tends to affect people who are at the peak of their career. So a large group of females with autoimmune disease, which exists more frequently in females, who are not just going blind, but also developing some disfiguring condition that affects their eyes. And interestingly, the vast majority of my patients were more concerned about the cosmetic aspect of it than the vision loss. oh yes, the vision loss was bothering them, but that was something that we could manage as doctors. We could manage, but the cosmetic aspect was not something that we were allowed to manage as doctors.
And that's weird, isn't it? You know, that's sort of really, I mean, it doesn't make sense.
No, it doesn't make sense at all. And medicine in the NHS is very disjointed in that way. It's improving.
Yeah.
There are multidisciplinary teams now, and it's all about multidisciplinary teams, some specialties in terms of improving patient care, but it's still very disjointed. So multidisciplinary teams is when you get, for thyroid eye disease, for instance, we would have a radiologist, an endocrinologist, ENT surgeon, ophthalmologist like myself, and then you would have a surgeon for the strabismus, the eye movement problem, and the surgeon for the orbital disease when the eye is bulging forward too much, and the surgeon for the lid disease, myself, and an orthoptist who monitors the eye movements, but there would not be a psychologist.
Yeah.
Or there would not be, there are bits.
A counselor or a therapist. Yeah.
No, we'd got so far with improving the management for this condition. It took me 10 years to get that MDT set up in Addenbrooke's, but we got it set up, and that's and I did a lot of research and published a lot on all aspects of thyroid eye disease. But the thing from the very beginning that I knew that we need to have was some form of support, not just myself, but some other form of support for the patients. And that was not something that we could have in the NHS. There was just no funding for that kind of thing.
I mean, it's not, it's not as if it costs much, with all due respect to sort of all sort of psychologists and sort of counselor. I mean, I've got a similar issue with dry eyes. And I think for me, if you can have an onboard counselor or an onboard therapist or psychotherapist or someone interested in the psychology of even dry eyes, I think it would make a massive difference, and you'd save so much money. Okay, drug companies may not be so happy, maybe, because they won't be using as much drops, but at least.
Sure, actually, I think the drug companies should be the ones that should be totally involved in this. And
exactly.
I mean, dry eyes is something that I'm very interested in myself as well, and we'll talk about that as well, because it's an aspect of it's one of the things that affects thyroid eye disease patients anyway.
It's modern living now, isn't it? It's modern living.
It is. 80% of the population will have some form of dry eye disease at some during some part of their life, and there are lots of things that we do to our eyes that can contribute to that, and there are lots of things that can be done that can help that. But a psychologist or the holistic approach is not something that we're able to provide. And I was sort of banging my head against a brick wall, and I wasn't able to provide the aesthetic support either. And I got, at that time, about 6-7 years ago, I got more involved in the aesthetic side of things out of the NHS, and I'd always sort of avoided going into medical aesthetics, and I call it medical aesthetics because it's the things that are still very taboo in this country, things like using toxin and fillers and these non-surgical treatments that are associated with quite a lot of complications and problems, because in this country anybody can do it, so you don't have to be a doctor to do it. But I knew that at some point when I was in Cambridge with my thyroid patients, I knew that actually that was the bit that was missing from the aesthetic side for my patients. So I had to wait for their disease to be inactive before I could operate. But during that time, these men and women were not able to go out of their house because they had disfigured eyes, which meant that they were not able to relate to people, speak to people, look into people's eyes. And this is the eye area is the area that is the point that we communicate with everyone. There are gaze-tracking studies that were done by Alfred Yarbus, who's a Russian scientist in the 60s, and he basically attached some electrodes up to some of his patients and monitored where the eyes focus when we talk to people. And so with these studies, it showed that actually you start by looking at their eyes, you focus on the midpoint area, the nose, mouth, if there are any scars, whatever else, you'll look at the scars, and then you'll rest back on the eyes. So the eyes are critically important for communication. And my patients' disfigured eyes meant that they were not able to feel comfortable going out of the house, keeping their jobs. They were not able to, maintain their relationships. And so it had a huge impact on them. And that's when I realized actually, vision loss isn't the most important thing for them. It's the fact that they don't feel able to go out of the house. And that's where psychological support and aesthetic support could have come in. And I was not able to bring that into the NHS to give that to them. And so I learned about it, and I started doing a lot of research and work and hands-on training in terms of using fillers and hyaluronic acid, which would have been able to drop patients' eyelids so that they had more comfortable eyes without waiting until their bulgy eyes had settled down on the drugs that I was using with the immunosuppression, or without waiting till 3 years down the line when they could have their decompression surgery, or without having to go down the route of having this sort of tarsorrhaphy, which is stitching the eyelids together, which actually can be quite a lot more nasty for the eye surface. And so
I mean, by that time they'd have lost their job, lost the relationship, financially would have been devastating for them.
Exactly. I mean, as a doctor, we see patients every 3 weeks, 6 weeks, 1 week, 1 month, or 3 months, or 4 months. But there are points of time, minutes and seconds and days, where these patients are suffering. And it's very easy for doctors to say, "Oh, you look better," or you can see better. These tests look much better. But these patients have been suffering that time, and I wasn't able to offer them anything for that.
I mean, hopefully, this is where technology can come in and sort of provide, a safer space for them, some kind of, sanctuary, virtual sanctuary, just to sort of get the ball rolling and sort of realize that there is other options for them and that there is support out there. So, technology going forward may be able to help with that. And that's something to kind of, as a second degree form of therapy delivery. I mean, having top-notch delivery is the best, and top-notch therapy is the best. But maybe this can be a stepping stone into other people realizing that the psychological aspect of healthcare is just as important as the physical aspect. Sorry, that's my 2-second rant there.
Absolutely right. No, you're absolutely right. And as a result, I mean, I presented at various of my oculoplastic meetings nationally and internationally, and there are now guidelines set up that have incorporated, if you can, get a psychologist or get a nurse support, that, and in more fields they now have that. We've had that for a few years, and Addenbrooke's, I was on the verge of getting that set up as well. And so yes, people do listen if you shout about it long enough, and patient support groups come in there as well. And I got involved with the British Thyroid Foundation, which is a charity that supports patients with thyroid eye disease, as well as other thyroid conditions, and ran some patient support webinars and educating eye care professionals as well as patient groups as well. And that sort of drive helped to get these guidelines set up, so that now the gold standard is to have some psychological support, but the aesthetic side hadn't come into that yet. And so that's where I sort of then headed towards in terms of the next challenge of how I could improve services further.
What's the name of the foundation? I didn't catch that.
British Thyroid Foundation.
Right.
The BTF. Right. Yeah. So it's the UK's biggest charitable trust for thyroid conditions, and it supports patients, and I'm one of their patient advocates in terms of support for thyroid eye disease. So
wonderful.
we were taking baby steps and we got somewhere, but it's still not there yet. And there are lots of other conditions that require that sort of that push and that support, like the dry eyes, as you say. And so, yeah, there's definitely.
Well, there's a lot of work for us to do. You know, there's no short. You know, we're not going to be short of work anytime soon in the next, you know, probably hundreds and thousands of years.
Yeah, and
no, I mean, you know, going back to the experiences that your father experienced back then. Now, and given that you've experienced what you've gone through, what would be your advice to him then? Because obviously, you know, you're a young lady then, and you didn't have the life experiences that you have now. What would you have kind of, you know, advised him, so to speak, when he was experiencing what he was experiencing back then?
Well, I would have advised him to persevere with it. You know, he ended up giving up his plastic surgery and became a general practitioner with my mother, and they both had a general practice together, and it was great from the financial point of view. You know, it was a stable career. They didn't have to move around. There was no further career progression or training and exams, but his passion and his heart was always in plastic surgery. And if he could have pursued his passion and persevered, he would still have been a plastic surgeon, and he would have got a consultant job, I think, somewhere. I think things changed, but he made a choice with my mother to bring up the young family in a stable place, not having to move around and take a financial decision, which was not necessarily, which wasn't the best decision for his own career progression and for his own self-fulfillment. Whereas, you know, I had the luxury of being able to persevere and go on to do what I wanted to do, and I ended up doing what I wanted to do. But there were still bottlenecks, and there was a glass ceiling for me. So after 10 years at Addenbrooke's in Ipswich, I very much was the single female doing this, surrounded by a group of male consultants who, in the oculoplastic surgery field, were not supportive. It was a network. It was still the old boy network, and here it wasn't the color that was the issue. It was a gender issue.
You were too good. You were very good at what you were doing. I mean, you're probably the best there.
Perhaps there is that. I'm sure there is that there is jealousy. But you know, I was naive. You know, I was very naive to that. You know, I thought that there is no healthy competition is always good. You know, you support each other so that you're doing the best for the patients.
And you get better as well, yeah.
You get better. And I suppose I was out in the sticks, in inverted commas. I'm not in London. In London, you can set up shop next to somebody else, and you'll have 100 oculoplastic surgeons. And it's not. I mean, there's still competition, and there's still all of that, the ego, but it's not the same. So yeah, it was probably the nature of where I ended up, and that there was only room for one or two, and that's what it was felt to be, I think. But anyway, so I then went through the pandemic. You know, it was as we all were, living in fear of what this horrible disease was going to do to us, and passing it on to our young families, 2 doctors as parents. My husband is an anaesthetist, and he ran the intensive care and the sort of and the anaesthetic department in Cambridge, and the sort of the first line of defense against the disease in the initial stages. And so there was this whole fear I forget when this all started now. Is it 2019, 2020?
Yeah, it was so surreal, you know, it's kind of a surreal moment.
That first time it was, are we both going to survive? That's when we wrote a will. We hadn't written a will before that time. We wrote a will. Are we both going to be able to look after our children? Does one of us have to give up our work so that we can stay at home? And so it was a difficult time and challenging time for everybody, but it was also a time to be able to rethink career choices, passions, and what to do next. And it was a time when a lot of our clinical work was shut. So I was still doing emergencies. In fact, the juniors were all moved to the COVID ward, so they had to deal with the worst of it in a way. The consultants were on call 24/7, and running the emergency ophthalmology care, and my skin cancer work was still going on at that time, and so that was the only thing that wasn't stopped, thankfully. But everything else was stopped. And also, with then, as I'm sure you went through this as well, we knew about the transmission from the eyes and with COVID, and we didn't have the tests, and we didn't know whether we were going to put ourselves at risk, and by operating on patients who hadn't been tested, and wearing the full PPE. I remember the first week I'd heard about COVID from November the year before, through colleagues in around the world, in China and in other countries, that there was something that was coming. And I made sure that I wore a mask all the time. And from the very beginning, I decided I was not going to wear the same clothes at work as I was wearing at home. So, I started wearing scrubs. And that very first week, I was told off by the hospital management for walking around the corridors wearing a mask. The very next week, it was the guidance in the hospital that everybody should be wearing masks. It was a difficult time for everybody, and the people who were making the rules were going by what they had to balance the decisions based on what amount of PPE was available, and what they should be doing. But it was a life-changing time, and career-changing moment as well. And during this time, I was also working on another project. So from the dry eye point of view, you'll know that actually blepharitis is a condition which causes a significant amount of dry eyes and dry eye disease and inflammation of the lids. And another unmet need that I felt during my work was that there are a lot of antimicrobials we use for asepsis in surgery. So we use iodine, we use chlorhexidine. I developed an allergy to chlorhexidine during my work and training, and it's not that uncommon. And I'd seen a lot of people with corneal burns due to alcohol, and particularly during the pandemic as well. People were spraying everything everywhere, and alcohol burns. And I knew that one of the unmet needs was that we didn't have an antimicrobial that was completely eye safe. And with my work in the aesthetic industry, I became aware of this substance called hypochlorous acid. And hypochlorous acid is something that's been used for over 100 years. So even before iodine started being used in the war, hypochlorous acid became known about. And it's something that our white blood cells naturally make to destroy pathogens. So it destroys bacteria, viruses, all sorts of things. And hypochlorous acid was being used and had been manufactured in other countries, in the US and other countries, for basically improving the purity of water initially. And then it was being used to treat blepharitis. And it is an antimicrobial that has no alcohol, that has no cytotoxicity, and is safe to be used on skin. And I became aware of its use in the aesthetic industry because a lot of my colleagues who were doing injectables with fillers and Botox were using this hypochlorous solution to clean the skin, as opposed to using iodine, as opposed to using chlorhexidine. And I decided that actually, this is something potentially that could be the thing that we're missing in ophthalmology, in eye care. And so I approached the company that makes this very high purity hypochlorous solution, CHT Limited, and I said to them, look, how can we make this safe for the eye, because the pH of the one that you have for the skin is not the eye pH. Can we make something that is the same pH as the eye and the ocular surface? Because all of the products that are available in other countries are made by electrolysis, and they're not. They leave debris on the lashes. They're effective at getting rid of viruses and bacteria, and you've shown it with your product for the skin. Can we make something for the eyes? And so I worked on that with them from 2018, and it happened to be ready at the beginning of the pandemic. So that meant that, in fact, I've got some bottles here. I've got the first prototype. This is the first prototype that came out, called Purifies.
Oh, wow.
I came up with a name and designed the bottle. And this is something that I sprayed in my mouth, nose, eyes, face, and patients as well. And I ran a clinical study. So this was for clinical studies. This hadn't not been trialed before. It was trialed, but this is for phase 1 studies on friends, family, patients, and anyone else who would be happy to be involved.
And in those days, you just want to get rid of all the virus,
Exactly. I wanted to get rid of everything, and it was perfect. I mean, touch wood, and I still haven't had COVID. Yeah. And none of my family has either. But the main thing is that I was using it for my patients post-surgery as well, because one of the things that we were seeing in publications that were coming out during the pandemic is that there was an increased incidence of infections post-operatively, because people were having to wear masks and blowing bacteria all over their eyes. There was more mask-related acne, but there was also mask-related eye problems. And post-surgery, once the lockdowns were over and surgery was back, and cataract surgery and all other surgery was back, then people were wearing masks and then getting infections in their eyes after their surgery. And I didn't have a single post-operative infection with this product. So all my patients got that, and they still get that now. In fact, the product has been developed further, and it's now got a blue bar on the bottle, and it's just been nominated as a finalist for a Product Innovation of the Year. And it's also available through Positive Impact, which is a bespoke opticians distributor, and they've also won Optician Supplier of the Year as well. So, I think
I'll be buying some.
I think that would be the next thing for preventing dry eye disease in the future. So perhaps we can get it down from 80% to much less than that. But yeah, I mean, the reason why I brought that up was because I had that as protection. I had the knowledge that there was something coming, and this was also, there were things brewing that were developing in terms of interests. And
how do you develop those sort of brewing realizations?
Well, I had more time because I was at home a lot of the time. We had the administrative work of working from home. I brought in, I was one of the first consultants in the region to be doing virtual consultations, because with oculoplastics you can do that much more than you can with ophthalmics. Because you can at least get an idea of eyelid conditions by looking at someone's face. And so I was at home doing some of the clinics, and I at least able to maintain my service, as well as spend time giving webinars, presentations, writing papers, doing more research. Yeah, it sounds a bit nuts, really. I should have just sat at home and done some exercise, which would have been a better option.
You had more time to be, into your creative mode and sort of being, so to speak.
I had the opportunity to do that, and I wasn't commuting in the car quite so much, and so there was more time available, and it was a good time to be able to do these things and learn more as well. And so yeah, it was an opportunity, and that's where I reached sort of crossroads, and I decided actually at that point I'd reached the glass ceiling. with my surgical work and NHS work, and I wasn't really able to provide the best care for my patients due to various different limitations. And so I left the NHS fully in February.
February of last year, 2021, yeah.
2021, yeah, now, because we're just under a year now. So again, losing track. And I was very fortunate that one of my previous trainees, Jonathan Roos, who is also an excellent surgeon, also trained at Moorfields, decided that he wanted to do the same thing, that he wasn't interested in necessarily getting to a glass ceiling. We formed this business called Face Restoration, and it's a very unique. I don't think there is a single plastic surgery team where two consultant surgeons work together. Unique, diverse teams. We have one male, one female, one brown person, one white person, and we consult and see patients together, operate together, and we publish, we present, and it means that we have really got rid of a lot of the obstacles and barriers that were there in the NHS. We're doing something that's quite unusual and new and unique, but also it's a way of giving to patients something that they don't have at the moment, and losing the ego from surgery. And there is a huge amount of ego amongst surgeons, and I'm very lucky that I found somebody who doesn't have the ego. And I have lost my own ego as well, to a degree. I have to accept that 10 years of experience as a consultant in oculoplastics and aesthetics, and I will share that with someone else so that we can provide the best care for our patients. And so I don't have the ego of being the main surgeon. It's a team approach.
I mean, it sounds like a yin and yang sort of relationship, and the balance is there between the feminine and the masculine. And that tends to work most times.
It does. It attracts patients, and patients feel listened to. We have the time to listen and do, because there's two of us, and there is always still the sort of gender issue that sometimes people will only refer to my male colleague.
Yeah. Well, cultures take time for them to develop, and we're all at different stages in our cultural development, and that's the way life is, because we're all at different stages in our journey. But coming back to the ego, ego creates avatars, and sometimes we outgrow our avatars, and we've just got to accept it and realize that there's more to life than just one avatar.
Yeah, no, absolutely. And so that's where I'm at the moment, and there is no glass ceiling anymore.
There you go.
There is no really, and I think it's just finding a niche, and finding a team of people that you can choose to work with, which we aren't always able to do in the NHS. You get a job, and you are working with who you work with. Your personalities may not work together, but they may, and if they do, then that's brilliant. But then also you may be doing things which you don't enjoy, and you need to have something that drives you to the next stage. And I certainly did, and that was the opportunity for me to make those decisions, and things were already being set up. So it wasn't an overnight sort of success, but things were already being set up to allow it to be to launch this sort of business, medical business, privately, without having to take the 10 years to get going that it would normally take for something like this, I think.
Well, I mean, you're a natural trailblazer. That's what it's about, really. You have this sense of knowing what's going to come around the corner, and you probably got that from your parents, because they they did a big step. I mean, same with my parents. I mean, my father left Iraq and decided to sort of, set shop here, which was a really brave move. And I guess that rubs off onto us and to the next generations, who are sort of in touch with us.
Mm-hmm. No, I absolutely agree. And we are disrupting the market because of that. But that is, as you say, it's not a bigger step as our parents took. Those
massive
steps
step,
much bigger. So,
well, I mean, we say that. I mean, probably our steps, because we don't realize it, because we're in the middle of everything. We don't realize how much of a significant effect we're having on other people. But the aftershocks will be quite profound. And, we won't, we may not see that physically, but God knows what's going to happen, metaphysically after, we move on. It's not really a very, logical way of thinking, really. It's sort of nonsensical way of thinking.
Nonsensical is always the way that, actually, in retrospect, that's what's going on. A lot of what I'm doing in medicine now, 5 years ago, people would have looked at, and I perhaps would have looked at and said, "Oh, this is rubbish." I know, going back to the psychology, when I was presenting at an international meeting in Singapore on thyroid eye disease, one of the audience, another female doctor from India, stood up and said, I get my patients to do meditation and yoga. And the largely male audience just laughed at her. But actually, autoimmune diseases are caused by stress. And we know now that actually wellness and mental health can have a huge impact on our well-being and physical health as well. And so, I
mean, that saying that it always starts off by them laughing at you. So that's like a really...
I just, it's like water to a duck's back, really. I don't bother getting upset about these things anymore, because people are laughing at you. At least they're paying attention to you, so you're doing something right. So
and the process of laughing is so complicated, but we know that it's quite significant, whether it's positive or negative. It's a significant human affect, so to speak.
And I just laugh with them.
Fine. I mean, it's nice to see the amalgamation of psychology and non-materialism with materialism, and I think that's where the next new frontier of traditional medicine we'll be looking into, and maybe even surgery as well, and this whole amalgamating robotics with art.
I don't know yet about, I mean, robotics, definitely, we've certainly got some of that, and art, but I think that we definitely need to be incorporating a lot of the metaphysical things and the nonsensical things into our practice, because they may not be nonsensical. One of the places that I work at the moment is called Lanzerhof at the Arts Club, and they are a private wellness facility, and they do a lot of things which 2, 3, 4, 5 years ago we would have laughed about. So like the cryotherapy chamber, which increases and improves metabolism, vitamin infusions. There are various different things that actually, it does make a difference. And although the scientific evidence may not be out there yet for some of it, it will be. And we need to be thinking about a holistic approach to our patients, and whether that's incorporating robotics or laser or other approaches to the care of our patients, whether that's going to be detrimental to the artistry. I don't think so. I think we'll still always have a job. We'll always need to apply the artistic eye, inverted commas, to the eye care for particularly for oculoplastics. You know, it's my signature that is on someone's face when I operate on the most important part of their face, and so it has to be artistic. It has to be scarless, and it has to protect the eye. And so they're all still important things. And whether robots can help with efficiency, probably can, but whether they can help with artistry, I'm not sure. So I think it's still an artistic eye that's needed. I mean, there are lots of studies that look at symmetry of people's faces, for instance. And I think a robot will create a very symmetrical face if it was told to operate on something. But actually, you know, I'm very asymmetrical. I'm not saying that I'm necessarily that good looking, but I'm very asymmetrical. And if you put two sides of the a split face together, and Jonathan, my colleague, has given a presentation splitting David Beckham into two. He also split me into two, but splitting David Beckham into two and put the two sides together. And actually, he's very asymmetrical. And if you put the two sides of David Beckham together to give symmetry, he looks very odd. You lose that good look. And that's the same for a lot of people who are asymmetrical. And I don't think necessarily that we want to be aiming for perfection, in inverted commas, by a robot. Yeah. I think the human in us will always look for some characteristic that is slightly different and unusual, and that's what's striking. And so that's where asymmetry is important.
Yeah. I mean, we've got to relate to people at the end of the day, and you know, we know that we're imperfect. So if we see a bit of imperfection, it kind of makes us a bit easier to relate to that person. I think
that's true. You want to be too perfect.
But yeah, I mean, it's sort of, I think robotics will be important just to sort of cut out the mundane things. And I think, you know, human beings are very good at, you know, creating routines very quickly, and we get bored with routine. So the robots can deal with the routine, and I think that'd be good.
I think that's entirely right. Yes, I mean, and there are some things that should be automated, and that can probably reduce errors, and that's where automation.
Yeah, you know, we can include the husband and wife in that as well for certain things. Yeah, put it on switch. I'm gonna get in trouble now anyway. But yeah. Yeah, I mean, it's interesting because I think art is, you know, is where the real deal is. You know, it's sort of essentially the real dance of life, and that's where, you know, music and art and creation and fiction and stories and, you know, all of these. I mean, you know, we shouldn't really call it human, but you know, they call it humanities. You know, and I think that's where. Exactly, yeah. You know, the social sciences are, and that's why it's really significant, because, you know, because we all have a stake in it, and I think that's where the real, you know, the real gem of what it means to be a human being is, you know, in these areas. And if we can amalgamate boring medicine with that, it makes all of our lives much more interesting.
Well, we all have hidden talents. Yeah. Whatever it is, there is always a hidden talent. And I think just because you're a doctor, it doesn't mean that is the only talent you have. And we will all have talents in some aspect of humanity.
And you know, it's not really celebrated as medics. I mean, that wasn't really celebrated for me. I mean, I was at Barts, and you know, I just felt the tradition of traditional Western medicine there, rather than any celebration of you know, the spiritual and the metaphysical, which I was really interested in, and the psychological. But then I couldn't really verbalize it and sort of logically create that within me, because I didn't have, I guess, the maturity to understand that. But hey, you know, I guess that's life's lessons, isn't it? We've got to experience life to sort of understand life, really.
Yeah, and you found it, and you know, that's the other thing. It's never too late. Never too late to find yourself, or to find your passions, or to incorporate the aspects of your life that you're not entirely sure about how to verbalize. But when you are able to verbalize it, it's never too late to do it. And I turned 50 last year, and it was setting up a startup.
Yeah. Scary. It's like scary stuff.
Scary, but there's no
Yeah,
reason
scary in the nice sense. Not in the oh my God, it's existential dread and so on. It's sort of like, yeah, this is like when I was back in just starting medical school, sort of thing.
Yeah, and I'm very lucky that I have the support network and infrastructure to be able to do this, and still be able to bring home a salary. And there are 2 children in school, and there's a house and a mortgage and all of those other things that have to be taken care of, and I'm able to do that. But I'm able to take the plunge because there is a support network there. But also, I think it's important for all of us to be able to do something that actually drives us, allows us to fulfill our needs, individual needs, whether that's career or family or whatever it is. And I still had that need, and making that change last year was the best thing that I've done. And in terms of quality of life, even though I'm probably working harder than I've ever worked, because it's very different when you're running a business. You take things for granted when you're in the NHS. You don't have to worry about ordering drugs. You don't have to worry about administration things. You don't have to worry about preparing consent forms and all sorts of things. There's so much that we take for granted, and it's having to suddenly do all of that with familiarity in the clinical side, but absolutely no familiarity in the business side. Then it's scary, but it is something that I was passionate about and I wanted to do, and very happy I'm doing it now. And so for me, it's not too late. It wasn't too late, and I don't think if anyone else listening in is thinking about making sort of career changes. I don't there's never a good time or a bad time. It's if the time is now, the time is now. So
yeah, I mean, if the drive and the motivation is there, then that that's it. That's all you need, really. Well, I mean, it's been an absolute pleasure, and I just realized that we've sort of gone on, and it's probably gone very quickly.
It has gone very quickly. No, it's been an absolute delight to speak with you, and it's great listening to your experiences as well. So thank you very much for having me on.
That's okay. I mean, I like to finish on this, and I like to ask our guests, what would you tell Rachna, who has sort of experienced what her father went through and about to start medical school, what at St. Mary's, what would your 3 top tips be to her, or what would you advise her if she came and saw you today?
Oh my goodness, you put me on the spot, haven't you, really? I actually gave a similar kind of advice to one of my friend's daughters who is applying for, going to do A-levels next to decide what career they want to take. And, what I said to her is what I would say to myself then as well, which is to find a career in something that you are passionate about. Because if you're passionate about it, you will not have any problems in getting up and going to work and enjoying the work and coming home, and everything else in your life will benefit from it. So that's the first thing. Do something that you're passionate about. The second thing is that, as I know now, it's never too late to change. And so don't worry about making the wrong decision. We spent a lot of time worrying about what is the right choice in medicine. What should I be doing? I don't worry about making the wrong choice, because you can always change. And the third thing is actually probably allow some time to for yourself. So we get very caught up with our work and the needs of others around us, because we are carers. We're in a caring profession, but sometimes that means that actually we don't allow time for ourselves, whether that is actually fulfilling our need in terms of career progression or whatever it is, quality of life, exercise, that kind of thing. I would say just from that very beginning, always make sure that I allow some time for myself and my own needs, and then everything else will also benefit.
Absolutely, total guilt-free, whatever, enjoyment, fun, self-care, whatever it is. Just enjoy yourself. Well, it's been a great pleasure speaking to you today, and thank you so much for sharing what you've shared today. And I'm sure it's going to be a wonderful inspiration for all the aspiring surgeons out there, and people that really relate to you and what you've gone through. What's the best way of people contacting you?
Probably through my, so I have my LinkedIn profile, so I'll follow you as well. And so do follow me on LinkedIn, that's Dr. Rachna Murthy, or on Instagram, Dr. Rachna_Murthy. Message me through that, and then I'd be delighted to get in touch.
Wonderful. It's been a great pleasure. Thank you so much.
Thank you, Haidar. You take care. Have a great day. Bye-bye.
Bye-bye.